Hello and welcome to the topic Inflammatory Muscle Disease in the module Rheumatology. By the end of this topic, you should be able to define inflammatory myopathies, classify inflammatory myopathies, describe the features of inflammatory myopathies, list out the investigations done to diagnose inflammatory myopathies, and explain the principles of management of inflammatory myopathies. Let's get started. We will begin with polymyositis. Polymyositis is an inflammatory disorder causing symmetrical, proximal, painless muscle weakness, thought to be a T-cell mediated cytotoxic process directed against muscle fibers, typically affecting the middle-aged group, with females being more at risk compared to males. Among the associated conditions with polymyositis include connective tissue disorders, malignancies, and adenocarcinoma of the cervix, lungs, ovaries, pancreas, bladder, and stomach, and this accounts for approximately 70% of the cancers associated with inflammatory myopathies. In terms of features, one would expect to see proximal muscle weakness with or without tenderness, Raynaud's phenomenon, respiratory muscle weakness, interstitial lung disease such as fibrosing alveolitis or organizing pneumonia, dysphagia, and dysphonia. Dysphagia is common, but the ocular muscles are very rarely involved, unlike myasthenia gravis where there's predominant features. In terms of investigations, you would expect to see elevated creatinine kinase, and that will usually be the initial investigation. Electromyography might be abnormal in almost all patients, that accounts for about 90%. There would be a triad of short, small, polyphasic motor units with fibrillation and sharp waves, as well as bizarre and repetitive discharges. Muscle biopsy is the definitive investigation to establish the diagnosis of polymyositis. Histopathologically, you'd expect to see endomysial mononuclear inflammatory infiltrates and muscle fiber necrosis. Endomysial inflammation with CD8 T cells are seen. Anti-Jo1 antibodies are seen in patterns of disease associated with lung involvement, Raynaud's, and fever. Positive rheumatoid factors are found in more than 50% of them. There would be positive myoglobinuria. A full blood count would show leukocytosis or thrombocytosis, and ESR or CRP done will definitely be elevated, and that will be for accounting to about 50% of them, as well as positive anti-nuclear antibody found in 1/3 of the patients. In terms of treatment, prednisolone is the mainstay of therapy at an initial dose of 1 mg per kilogram per day. In patients who fail to show improvement, disease-modifying steroid-sparing agents may be added. A high-protein diet and supervised exercise may further improve the symptoms. Prognosis-wise, most patients have favorable response to corticosteroid therapy and a 5-year survival rate approaching 80%. The next condition would be dermatomyositis. This is an inflammatory disorder causing symmetrical proximal muscle weakness and characteristic skin lesions. It can be idiopathic or associated with connective tissue disorders or underlying malignancy, typically lung cancer, which is found in 20 to 25% or more if the patient is older. Polymyositis is a variant of this disease where skin manifestations are not prominent. The autoantibodies binding to the vasculature, muscle atrophy, and lymphocytic inflammation caused by CD4 T cells are the cause of perimysial inflammation and atrophy. Among the skin features you'd expect to see include photosensitivity, pruritus of the skin lesions sometimes intense enough to disturb sleep, shawl sign, which is the macular rash over the back and shoulder, V-neck sign, which is a violaceous erythema or poikiloderma involving the anterior chest, heliotropic rash, which is seen in the periorbital region. The characteristic heliotrope rash consists of a violaceous or erythematous rash, sometimes with edema, in a symmetrical distribution involving periorbital skin. This is frequently subtle and may involve only a mild discoloration along the eyelid margin. Since the heliotrope rash is rarely observed in other disorders, its presence is highly suggestive of dermatomyositis. Gotron's papules are seen, and these are roughened red papules over the extensor surfaces of the fingers. Also seen would be Mechanic's hands and fingers telangiectasia, which are nail fold capillary dilatation. As for the investigations, elevated creatinine kinase is the most helpful test in the diagnosis. An EMG can be done, and a muscle biopsy would show high levels of the complement component C5b to 9 around the capillary vessels, perimysial inflammation with lymphocytic infiltrates. ANA will be positive in 60%. Anti-Me2 antibodies are highly specific for dermatomyositis. Anti-Jo1 antibodies are not commonly seen in dermatomyositis but are only seen in around 25% of patients. Don't forget to screen for malignancies, and treatment-wise, we usually initiate prednisolone. The next type of inflammatory myopathies in short we'd like to cover would be inclusion body myositis. This is a syndrome of diffuse, progressive, asymmetrical, proximal and distal weakness that is generally refractory to immunosuppressive therapy. It's one of the cause of myopathy associated with cytoplasmic inclusions on muscle biopsy. The pathologic findings involve both inflammatory and degenerative characteristics. Like in polymyositis, inclusion body myositis presents with an increased sarcolemmal expression of MHC class I antigens. As for the epidemiology, inclusion body myositis occurs more frequently in men than women. They are more common in older Caucasian males, and the most common acquired myopathy in patients older than 50 years old. It accounts for about 16 to 28% of inflammatory myopathies in the United States and Canada. In terms of features, muscle weakness can affect both proximal and distal muscles. Unlike polymyositis and dermatomyositis, asymmetry is common. Characteristically, it affects quadriceps and the finger or wrist flexors. They are usually more severely affected than extensors counterparts. The onset of muscle weakness in inclusion body myositis is generally gradual, and dysphagia is common, occurring in about 40 to 66% of patients. As for complications, dysphagia due to weakness of the cricopharyngeal musculature may predispose to aspiration pneumonia. The most common cause of death is respiratory system disorders. Diagnosis is made through an anti-CN1A autoantibodies. Muscle biopsy shows intranuclear or cytoplasmic tubular filaments on electron microscopy. In terms of treatment, poor response to immunosuppressive therapy or immunomodulatory therapies. Polymyositis and dermatomyositis show a much better response to steroids than inclusion body myositis. This is a table that delineates the differences between polymyositis, dermatomyositis, and inclusion body myositis, which are components of inflammatory myopathies. We have come to the end of this topic. Thank you.